All right, so I got the recording going. So, okay, I've got 5 cases here. Let me, nothing terribly exciting, but somewhat interesting. Let's see if I can get this one to load. All right, and then I have to, let's see, you should be able to see a radiograph. You see it?
Yeah.
Okay, so this is a kidney transplant patient who presented with cough and fever. And you can see there's a nice area of consolidation in the right upper lobe, consistent with infection. They ordered a CT, and I think it's an important point for everybody's. In the most cases, it's a clinical diagnosis of pneumonia. The CT usually, in my experience, does not add much value. And you can see, there's the CT. You can see we have consolidation, ground glass in the upper lobe, nicely marginating the fissure. There's air bronchograms. Looks like your typical lobar pneumonia pattern, right? Ground glass in the middle, a little bit in the middle lobe. And that was it. And when I read these out, I still just read them as infection because honestly, this could be just about anything. I mean, with bacterial pneumonia, other things like that. But what's interesting is this ended up growing out nocardia. And usually nocardia presents more as masses and nodules, usually multifocal. I kind of lump it in with my Aspergillus cryptococcus differential when I see multiple nodules or masses. But this was just a single area of consolidation and wasn't high on my list. And interesting, the incidence of nocardia apparently is down just because of pneumocystis prophylaxis with Bactrim. But anyway, a lobar pneumonia that was caused by nocardia instead of the usual suspects. All right, this is kind of a cool case.
Jeff?
I'm sorry?
Jeff, was your patient compromised, or was it, I missed the first part, was it just on the flu?
It was a kidney transplant.
Got it.
Yeah, nocardia is almost always opportunistic. Very, very uncommon to see it as community acquired. But it's and the other important thing is it's not it doesn't live in the human body. So if you recover it, it's either real or your lab is contaminated. Okay, so this is a patient with a history of kidney cancer, and I'm showing the radiograph, and some of you may see some findings. If you look carefully, there's these thin wall lucencies, predominantly in the lower lobes, so maybe some cysts or something like that. But that's, if you're not paying attention, or just it can be very subtle sometimes to see these on the radiograph. Here's the lateral. I think you can see them better, particularly anteriorly here. You've got a nice cyst, and there's another one here. Let's see. So here's the CT scan, and go down. You can see there's been a nephrectomy. It's not on this one. The patient had a nephrectomy, a different scan. But what we see, all these big, thin-walled cysts. Some are along the pleural surfaces. Some are running perpendicular along the septa. But clearly a basal predominance. This one's interesting in that there's vessel running right through it. And I remember when we first saw this case, with the history of kidney cancer, of course, we thought about Birt-Hogg-Dubé. There was no mention of skin lesions. But the number of cysts and the fact that so many were perivascular also made us entertain, well, could this be like an LIP or some other lymphoproliferative disorder? And finally, the physician taking care of this patient was able to get the genetic tests in, and this is a Birt-Hogg-Dubé case, but I have to say it's one of the ones with the most cysts I've ever seen, and they're not all of them are the usual. I mean, I think of cysts like this with Birt-Hogg-Dubé, sort of elongated, biconvex, ones running perpendicular to the pleura or along the veins, but I haven't seen so many arterial ones like this guy up here, and a couple up top like this one in the right apex. So I don't know, it's not something we see all the time, but I was curious if anybody's seen one that had this extensive amount of cysts and sort of a little bit more unusual morphology.
Yeah, I showed one, and I think it was a week you were gone, that had as many cysts as this, if not more, and it was very bizarre. I'll try and pull it up while you're looking at some of your other cases.
Okay.
But yeah, it does violate the rule that usually you can easily count the number of cysts and usually along the fissures, etc.
Yeah, see, like on the coronal, you see how this one's sort of biconvex. That's the typical appearance I think of. And these guys right down here, very typical of Birt-Hogg-Dubé. But some of these other ones, just I just had not seen them. And maybe it's because there's so many cysts, we catch them in the earlier phase of development. So,
Jeff, do you know what kind of renal tumor it was?
it was a renal cell carcinoma. I don't know specifically what subtype, but it was not an oncocytoma or other one. Okay, this one is I think in the operating room right now, but we pretty much know what it is. This is a young woman who presented with dysphagia. And I love the radiograph because you can see the azygoesophageal recess is displaced, and there's this density under the left main bronchus. Let me show you the lateral. And this is just a nice multimodality, but you can see the infrahilar window is filled in as well. So a nice subcarinal mass. And the next thing that was done in this sequence is a CT scan. And the CT scan shows, you should see that, there we go. CT shows a very homogeneous subcarinal mass, fairly low attenuation, but it wasn't water. It was, I think, about 30 or so Hounsfield units. But notice how homogeneous it is. I mean, it's noisy. It's a low-dose scan. There's some artifact from contrast. This was, I think, actually a PE study. The absence of contrast made it easier to see. So an MR was done because this was suspected to be a bronchogenic cyst, just to prove, and I'll just show this one sequence, this fat spread. But you see a nice fluid level in it, which you really don't appreciate on the CT. A little ice cream sandwich or something. So the thought was this is a bronchogenic cyst, but somewhere along the way, someone entertained the idea of an esophageal duplication cyst. Not sure why or where that came from. And they were going to do an endoscopy, but luckily they didn't. Instead, someone did an esophagram, which I know David Chuck Mormon would like this case. You got a really nice esophagram showing the extrinsic compression. Let me show, this is a cine here. You can watch it go down. So this fixed extrinsic compression, no communication. So it's not communicating. So this is presumably a bronchogenic cyst. I've asked the surgeon for some photographs, but I think the patient's actually in the OR right now getting this removed. Right age, right location, has all the good imaging features of it. So just a really fun case. But it's a nice radiograph case to look at the azygoesophageal recess.
Hey, Jeff, quick question. Do you try and make a distinction between bronchogenic and esophageal duplication cyst? Because in my mind, they're both foregut derivatives, and I've been fooled on pathology when they see respiratory epithelium where you expect esophageal or vice versa.
Yeah, honestly, I call them foregut duplication cysts too, but in that location, I mean, it's so classic for a bronchogenic one. But you're right, you make a very important point that sometimes you do get fooled. Okay, this patient also had some dysphagia, and I wish they'd done an esophagram first. It seems like everybody wants to go to CT first, but CT...
Not seeing any images yet.
Sorry, I got to hit this silly button. There we go. So CT was done. I don't have a radiograph, unfortunately. It shows this subcarinal mass with these dystrophic calcifications and right up against the esophagus, pushing it over. Now, of course, we see a lot of histo here. We see a lot of calcified nodes, but this is quite large. And it seems to not push this esophagus over a lot more than we'd like to see. But I think the esophagram is actually better. So here is the swallow, and you can see that is actually, this is in the wall of the esophagus, and it's a fixed filling defect. And you see the irregular contours there. I have another sequence here showing that as a patient swallows, you see that fixed defect there, that irregularity right around there. So we favored this being a leiomyoma, and indeed that's what this was. So this is an esophageal leiomyoma. So we have a bronchogenic cyst that's causing extrinsic compression. This is part of the wall, but they're usually submucosal. And then this, just the third esophageal case, my last case this is an interesting case, and I'll share the screen in a second. So this is a woman who has AFib, and I'm going to show the screen. Had a benign esophageal stricture, and about 7 or so days ago had a dilation. And she was on Coumadin, and this was done somewhere else, was on Coumadin for her AFib. They did, and as far as we know, she was still on it. They did the dilation, and she did fine. But over the subsequent days, she developed progressive dysphagia and some burning sensations. So she went to a hospital, and they did the CT of the neck here looking for this, and saw this mass right behind the trachea here in the region of the esophagus, and then you can see there's some active extravasation of contrast in this. And we have a chest CT from here. This was done the next day that shows, and it's non-con, and you can, so at this point she's intubated to protect her airway. And you see this high density column associated with the esophageal lumen, which is right hiding in here, and then the central low attenuation. And this is all blood in the wall of the esophagus coursing down. A little bit of mediastinal blood. She had these effusions out of atelectasis, probably a little bit of heart failure going on to account for that. So this is an intramural hematoma of the esophagus. I don't have any images of what they dilated, but it sounds like it was a proximal stricture, so somewhere up in this region here. And they did scope her later after the CT and saw a bunch of ecchymoses along the mucosal surface, reflecting all this intramural blood. So yeah, this was pretty bad. Not seen we've seen dissections of the esophagus, either following retching or endoscopy where you get a little gas, but I've never seen a hematoma this big, and it's probably exacerbated by the fact she was on warfarin at the time. I don't know. Have you ever seen anything like that?
No, thank you.
Pretty impressive.
Yeah, it's pretty bad. So hopefully she'll be okay, but there was that active extrav, which was a little concerning. But they didn't see any perforation on the endoscopy, because that was one question raised, but we didn't see any gas or anything either. So, okay, well, that's what I had, Travis.
Okay. I'm going to show one really quick, and then I'm going to hand it over to Brent. I just want to show the Berthog-Dubé case I have. You see my screen?
Yep.
Okay. We'll start at the bottom, because this is one, and I'll show you the genetics in a second. But Jeff, like you're saying, some of them are the typical configuration, some along the fissures and the subpleural lung, but like some of these elongated ones along the fissures. But this guy just had cysts everywhere. And some of actually, maybe there's one that has a little vessel passing through it as well. But it still has a lower lobe gradient. And this was one that came to our ILD conference a couple years ago. And he was first diagnosed in 1987, had a couple of spontaneous pneumothoraces, and then they eventually did do the folliculin genetics test, and it was positive for this mutation commonly seen in Berthog-Dubé, as you can see. And I don't think he had any renal disease. I don't know if he had any facial disease or not, but I don't know if it's a form fruste from this mutation or not, but this was by far the most severe case I'd ever seen, and we weren't suspecting this prospectively. So, all right. Brent, would you like to go? Brent, yeah, you're there.
I'm here. Yep. Thank you very much. And I'm just going to pull up something here. Let's see. Okay, let me choose this. Okay. Can you see the screen?
Not yet.
Oh. Okay.
There we go.
Okay, great. So this was, I believe, a 20-some-odd, late 20s patient who presented with this as an incidental finding from an outside hospital. And you can see the finding down here in the right lower lobe. We have this this strange anomalous artery, and you can see that it's arising from the upper abdominal aorta right here, along the place where you might expect, the celiac there, and this vessel is rising just above that, and it's headed toward, has some tortuosity, some wall calcification, and it's headed toward the right lower lobe there. I'll show you the lung windows here, and you can see that there is really no associated soft tissue in the lower lobe there, and the bronchi are normal. Let me show you what was done. So this is not a sequestration. So this is isolated systemic arterial supply to the lung. And in this case, it was the right lower lobe. And I was just reading a little bit more about these, and apparently some case reports have shown not only rupture in some of these, but also because of the early atherosclerotic disease from the high pressures within these, they can actually, there are some case reports of dissection of these. So, which is something I've never seen before, but interesting appearance there. But let me show you what was done. No symptoms in this case, but in this case, this was the angio that was done from the abdominal aorta, and you can see that the blood supply.
Not seeing it yet.
Oh, sorry. Yep. Let me get the. Yeah. So we have an angio here from the abnormal vessel coming off of the abdominal aorta, and you can see that it's supplying the lower lobe, and then as you go on, you can see that it's being drained through the standard pulmonary inferior pulmonary vein here. So, and I'll show you what was done. Some coils were put in that, and that thing was embolized. So, not sure how many cases of embolization of these just instantly found you all have seen before, but presumably the idea is that, you know, sometimes these can be prone to rupture. I mean, often they're just watched. I know we have a couple more that are just being observed, but I just thought that was an interesting case of systemic arterial supply to isolated systemic arterial supply to a lobe. So, and what has your all's experience been with those? Are they, have you found that the larger ones they're going for embolization or what?
I've never seen one that was treated that was this large. I'm betting that David or Howard have.
No, I haven't. I've seen maybe one or two cases, but never one this big, never one so dilated with calcification and so on. Nope, never seen that one before.
Brent, was the pulmonary vein dilated as well, picking up all this extra circulation?
Let me actually go back. I can't by memory. Let me see. Let me pull that back up and we can look at this. Okay.
And assuming his arterial, or sorry, his airway anatomy was normal too, that he didn't have any other abnormalities?
He didn't have any other airway abnormalities. And so in the pulmonary vein here, the veins, you know, not really that enlarged. So just a curious case. So
was it picked up on a radiograph first, or was this just a CT done for another reason?
You know, this was a series of events that first occurred in an outside institution, and then it was transferred. So I'm not sure what the first study was. So anyway, just in the same congenital category, let me show this case. And this is just a really quick case because, you know, I can't remember the last time I got to actually see one of these close up, but this is a patient in, I believe in the early 40s who had a prior, I believe, a TET repair here. And look at the aortic valve. Let me just start this. So you can see that it's a quadricuspid valve. And you can see that you have 4 sinuses of Valsalva and 4 leaflets there. And of course, you can see that there's incomplete coaptation of the valve leaflets there, and it suggests they were, you know, representing aortic insufficiency there. So just a really nice. Let me show you another couple of series here. Here's another sonate of the quadricuspid aortic valve. Let me show you another. Here's perhaps a better one of the quadricuspid aortic valve. So just a quick case, but just very rare. You know, I don't see these very often, of course. So, and maybe just one more case. Actually, this, yeah, let me show this case because this is a good instructional case, and this is courtesy of Eugene Berkowitz, one of my colleagues here. And he showed me this really nice case. Let me show you the, hold on one second. Okay, there we go. And this is a CT that was done for planning, and part of planning for repair of this. But you can see in scrolling through the septum here that there is this contrast that seems to be left atrial in character that is crossing the septum across to the right atrium. So at first glance, you might say, well, you know, is this a large secundum ASD? But you know, as we always recommend that the residents do, look at the right heart. So the right heart here is not enlarged and it's not thickened. The wall is not thickened. And so it'd be really unusual for this to be a wide open ASD with a huge shunt going through this. However, it's a good lesson here because interatrial septal aneurysms can mimic large ASDs, but they're also associated with small ASDs and with PFOs, and so you can't really see very well here, but there were actually two small PFOs, tiny PFOs, 4 millimeter PFOs picked up. One was close to the septum down here, and one was, you can even imagine that maybe it's right there, but two tiny 4 to 5 millimeter ASDs were picked up here, and there was a shunt that was measured to be about 1.2 to 1. So nowhere near the large shunt that you might expect, but it's a nice case of a interatrial septal aneurysm that kind of mimics a larger defect, but is also associated with smaller ASDs. So I just thought that was a really nice case here of that. So,
are they going to do anything about it?
Well, I mean, I don't know why, but I think they were considering doing something about it with that small shunt. You know, not sure that everyone would do that, but I think they were planning for repair of this. So, you know, it was a very small shunt by measurement. So, but anyway, I just thought that was a good case. And let me just show one more because I know that Travis and I have talked about this phenomenon before. Let me show you the window here. Hold on one second. This is my last case. Okay, so this is a patient, history withheld for a second, in the mid-30s, aged mid-30s, who has this, and I'll show you the mediastinum here. You can see that there's something abnormal here in the mediastinum, and it's coursing adjacent to the aorta, and you might, in this location, you might think about, you know, some extra duplicated SVC. You might think about a left superior intercostal vein that's a little dilated. However, it's not enhancing at all with contrast. It's not filled with contrast, and it kind of tapers down to nothing right here. And let's follow that down. Really does not look like a vascular structure at all. But the question is, and it kind of ends blindly right there, does not connect with the hemiascus system, so it's not filled with contrast. So what's the portion of the story, of course, on withholding is look at the skin here, and you have multiple, you know, numerous skin lesions here. This is a patient with neurofibromatosis, NF1, with multiple skin neurofibromas, and this is a presumably a plexiform mediastinal neurofibroma along the course of nerve here, you know, maybe the vagus nerve. But it's when we found that when you look for these, you can see them in a high percentage of NF1 patients. You know, little tubular structures in the mediastinum that are little, presumably plexiform neurofibromas along the courses of the mediastinal nerves. So just wondered what other people's experience with those was.
You think that's the phrenic nerve right in front of that? Keep going down. It looks like something bifurcates.
Yeah, I knew you were going to mention that. Yeah. Are you talking about this?
Can you track
yeah,
that goes down to diaphragm. Maybe it goes all the way down to the diaphragm.
Yeah, you can almost trace it. Yeah. Yeah.
Keep going.
Yeah. I'm losing it here.
So check out, switch to a long window, as you can sometimes see the phrenic nerve sweeping off the mediastinum to the diaphragm. You see that little peak?
Yeah.
Follow that down. I'll bet you that sweeps out to the diaphragm at the bottom.
I'm losing it.
I wanted it to. Going.
I
It's
can
not too
imagine.
late. No, farther,
Oh,
down.
okay.
Down. Keep going.
Is it there somewhere?
I think you were probably seeing that. Yeah, it probably is higher up, and it would kind of lose it down below, but then it's in the right location the last time we saw it along the mediastinum. Cool.
Yeah. Wow.
Hey, Brand, it looks like he had a few lung cysts too. I didn't see how I saw at least 2 or 3 of them.
Yeah. Yeah. Had a few lung cysts as well. So has a little bit of ground glass, I think, on this that you can see. Yeah, in here too. So, but anyway, I just thought that was a good case of a mediastinal, presumably plexiform neurofibroma.
Cool.
Okay, that's all my cases.
Awesome. Howard, do you want to go next?
Why don't you go and then I'll end up at the end?
Okay. David, do you have any?
I do have some.
I have a quickie.
Okay.
Can people see a röntgenogram on the right and a CT scan on the left?
We do.
Okay, so this is a person who has this obvious pneumonia down here in the right base. That turns out not to be a pneumonia, and the lateral view shows a pretty steep pectus excavatum there. So this is probably a pectus pseudopneumonia. And this CT scan, I think, shows where we get this extra density and the obscuration of the right atrium. There's a lot of tissue that's medial here, and the path length on the chest radiograph of an X-ray beam going through here picks up a lot of all of this whiteness here, which increases toward the center of the chest, and then V's off toward the edges. So I think we get an increasing whiteness medially. This is probably the source of some of the whiteness that we're seeing over here. And then with the mediastinum being squeezed off to the right, we don't have a very crisp tangent here to the lower mediastinum to give us a sharp right atrial border or right, in this case, right inferior vena cava border. So the obscuration of the heart border and the extra whiteness, I think, are explained from this CT anatomy. The extra soft tissue here anteriorly, squeezing off of the heart to the left, and then not a good tangent available to give a sharp border of the mediastinum there. So this was a pretty dramatic example of pectus pseudopneumonia. I think we have the anatomy to support it. And I don't have a chest CT. This is the top slices of an abdominal CT. Nice to have a chest CT and then do thick slabs in a coronal projection and work our way back and see if we can locate the whiteness more precisely with this. But if I had a better CT, we'd be able to do it. I don't have a good CT for it in this case. So pectus pneumonia.
Yep, very good.
Okay.
We like it.
Okay. That's
Nice.
a crazy paving pattern of ground glass, sharp margination against spared lobules, and the overlying reticulation here. This person was treated with lavage, and about a year later, almost all this stuff was gone. So I think more than one lavage was needed to clear this up. And she was not treated with GM-CSF, and she didn't have the antibody studies to document that was the cause of her alveolar proteinosis. But this is one of the nicest cases of crazy paving that I've come across. I wanted to share.
Great.
Okay, those are my 2 quickies.
Great, thank you. All right, I'm going to show a few, and then I will hand off to Howard at the end.
No rush.
We had some interesting stuff come in yesterday, and I'm going to start with this one. And this is only one series, and you'll see it's an abdomen and pelvis CT. This was done overnight, and the story with this, and one of the teaching points is that they had called us to do a PE protocol study, and the technologist was calling because it was less than 12 hours after this patient, or about 12 hours after this patient had received contrast for an abdomen and pelvis CT. And so I told the resident, well, let's look and see if there's a PE or anything else to potentially avoid having to do this study, or see if there's an explanation for the patient's symptoms. And it turns out there was, and I know Brent will like this. And instantly, when the resident pulled this up, I saw this on this abdomen pelvis CT, which you can see is decreased subendocardial enhancement, in the LAD territory. And it's largely confined to the LAD territory. And often, because the abdomen and pelvis CTs are more delayed, we get a better look at this. So they weren't really expecting an MI, but we quickly called and steered them away from doing a PE protocol. They ended up doing an echo next before they took the patient to the cath lab. And I'll show you a little bit more about him, why he actually got the study, is that he came in, he's an alcoholic who had fallen and had this massive hematoma in his right gluteal region in his right thigh. When they went to cath, they found that he had a 90% LAD, proximal to mid LAD lesion, which certainly confirmed this and explained why he had this finding. And they chose not to treat it yesterday just because he has some sort of bleeding diathesis right now, and they're not exactly sure why. So they're going to wait and see, especially since it wasn't completely obstructive. But I think the combination of his severe lesion and probably his hemoglobin being decreased from the big hematoma created a situation where he had more severe ischemia and had this non-ST elevation myocardial infarct. And his troponins that they had checked this one around the time of the CT. They hadn't really been paying attention to it, but by yesterday they had trended upward. And by last night they were still continuing to trend upward. But this was another example of an MI, myocardial infarct, as an explanation for symptoms incidentally discovered in its acute phase.
So, Travis, do you think they could have stented that 90% stenosis, or?
Yes, and they are going to. It's just because he's bleeding, and they're not exactly sure if he has some sort of coagulopathy. They didn't want to stent him yesterday, but they plan to take him back to the cath lab once they figure out why he's bleeding, if they can figure out why it is and reverse it. And they don't know if it's because he's an alcoholic and he has some cirrhosis and that's leading to his bleeding diathesis or not. But they elected not to intervene just because of the risk of it, I guess, either dissecting the vessel or occluding the stent. But their plan is to go back. And not surprisingly on the echo, because the other thing that I've seen in a few of these cases now is notice how the basal portions of the LV myocardium look a little bit thicker, and you are starting to get a little bit of ballooning. And I think the difference between this and a Takotsubo or stress cardiomyopathy would be that you wouldn't expect to see this profound degree of decreased subendocardial enhancement. So that's one, and then I was showing this around to the other residents in the reading room, and one of the residents said, well, we saw this case a couple weeks ago when I was away, and this is one that was a PE study. Actually, no, this is the study. It's a PE study followed by an abdomen and pelvis CT, and you can see here similar finding. Pretty subtle on this case. It's much more subtle. There's more motion, but you can see consistently there's lower attenuation in the LAD territory. And this, of course, was a chest CT, and you can see that he has reason to have that. He's got a bunch of calcification. He's had a couple of prior stents too. But this one also had an abdomen and pelvis CT, and you'll see that this is slightly more delayed, and sure enough, again, confirms that there's decreased enhancement in this territory as well. Now, this was a patient who came in floridly septic from his pyelonephritis, and you can see his right kidney is enhancing a little bit less than his left, and he's got a little striated nephrogram and stranding around there. And so his troponins were up too, and they diagnosed him with a non-ST elevation MI as well, and they thought it was from demand ischemia due to his sepsis. Now his troponins peaked at 9 and stopped rising, so they didn't take him to the cath lab. But this was actually a new term for me. They called it a type 2 non-ST segment elevation MI. And so I was looking at the classifications, and if you see this, there are 5 different types, but really there's 2 that are important. Number 1 is an acute MI based on plaque rupture, and I think this introduction actually has a nice, an acute atherothromboembolic event. And then type 2, which both of these are, is much more diverse group, but it's, as it says here, an imbalance between oxygen supply and demand. So in both of these cases, they weren't obstructive coronary disease or acute plaque ruptures, but they were just due to imbalance between supply and demand due to stenosis and either sepsis or, in the first case, the hemoglobin drop. So I thought these were both very instructive cases, and this is always something that I look for as an explanation for chest pain.
Nice cases, yeah.
Those are great cases.
And I was just giving a talk on this subject at one of our CME courses last week, so it was nice to see 2 more come in. All right, this one is dramatic. Actually, no, I'm going to skip this one. That one. I'm going to go to this one right here. This is from yesterday as well. And this was a coronary CT that was being done as part of a liver transplant evaluation. And this is a patient who's had a prior liver transplant. He's being listed for new liver transplant. He's got all of the surgical clips here you see on his old radiograph. He's had prior coils for variceal bleeding. And I noticed this, his calcium score, he does have some calcium in his arteries, but he's got something denser than calcium in his pulmonary arteries that you see here peripherally. So I saw this and I instantly thought this was going to be methyl methacrylate embolization. But the problem was I looked at his chest, I don't see any vertebroplasties. I looked at an old abdomen CT, didn't see any vertebroplasties. But what's curious, and if you look at the scout here, is that something else has happened in the past 5 days. These are, or 6 days. You can see there's new material in his right upper quadrant, or sorry, left upper quadrant. I'll show you the coronary CT just to prove that they are in the pulmonary arteries as you would expect. You can see some of them accompany, like this one accompanies a bronchus, so you know it's an artery. And this one looks like a little acute hemorrhagic infarct beyond this now. But to make a long story short, in between these 2 studies, or do you guys want, I'll throw this question out there. Do you know what they did in the interim? What all of this stuff is?
Did they add some glue or something like that to the coils?
That's exactly right. Yeah, so this is a glue embolization so the glue embolized, the purpose of the glue was to further occlude his varices. So I had never, so it's similar to methyl methacrylate. It's some sort of other acrylic that they inject into his varices. So they had done that 2 days before this. He was asymptomatic. The coronary wasn't being done for acute symptoms. It was just being done as a further part of his workup for re-liver transplant. So yeah, and there are several cases in the literature of glue emboli. There was one case that was fatal. I didn't pull up any of the specific journals, but yeah, I had never seen this before, but it certainly fits with the picture and the time frame, and it looks exactly like methyl methacrylate embolization. So I talked to the hepatology service yesterday, and it's something they look for, but he was asymptomatic, so they're just going to follow him. But this was the first case of glue embolization I've seen. So we can add glue to cement embolization and all the other different things that embolize to the lungs. All right, and then I'll show one more. This is kind of a quickie. We'll do some radiographs here. And there's one of our radiologists that likes to, this is one of our other institutions, likes to call microcardia in a lot of cases, and especially in older patients who have emphysema, where I think it's actually the opposite. And I've told the residents that I will wait and find them a real case of microcardia. Well, I think this counts as a real case of microcardia. This guy is in his 20s, and you can see he has a very small heart relative to the rest of his chest. And also notice the complete absence of any subcutaneous tissue really at all. And you can see even his supraclavicular fossa are shrunken in, and he doesn't even really have much of a supraclavicular companion shadow. But he has, this was his admission radiograph this time. So he has active anorexia, but despite that, I guess he still does have issues with aspiration. And he came in encephalopathic from his anorexia. And you can see now these nice little centralobular nodules and nodular foci of consolidation. Well, I assume they're centralobular at the lung bases. And then a few days later has more discrete consolidation in his right lower lobe. And so you'll see on this CT, and again, notice there is absolutely no soft tissue to this guy. Even look at his back and how he has no paraspinal muscles and no fat in his back. and he now has a necrotizing, presumably aspiration pneumonia with his microcardia. So this is anorexia. I guess my differential that I was always taught for microcardia is Addison's disease, anorexia, acute dehydration. Those are the ones I think of, rather than the more typical pseudo-anorexia that you often see with a patient that has chronic obstructive pulmonary disease. But just to give you a sense, he is 5'5" and he weighs 41 pounds. So it's pretty dramatic.
Wow.
I don't know. Yeah.
It's his blood volume that's just basically small?
It's his blood volume that's small. Yeah, I don't know what. Again, it's not really. It's more of an academic diagnosis when you say somebody has microcardia. But that's one of the things that's often one of the things that's in the differential. So
Travis, you don't like the term applied to people with COPD or cystic fibrosis or something like that when they have.
I don't know. I was always taught in the true sense of with it being a small heart, within the body, rather than like a normal size heart with a big chest. So I mean, I don't know. I just thought it was an interesting discussion case, just because it's such a dramatic case of findings of anorexia.
Mm-hmm. Travis, I think your point is valid, because I kind of take the same approach that in this case, I mean, there's probably muscle wasting, and just from lack of protein calories, rather than the pseudo microcardia where it's a relative proportion. Because if you have COPD but you otherwise have nutrition, you wouldn't expect your heart the muscle mass to shrink.
Right, and yeah, as I was just looking up there too, and as I've seen before, that anorexia does lead to heart failure too. So I guess I'm just guessing that there's muscle wasting just like there is in the rest of the body too. But I'll look it up more and try and get you a better answer. But that's it for now. I'll save the rest for next week. Howard, you want to show some?
All right. Sure. Okay, so this one is going to be, hold on a second. Seems to be frozen. This is going to be a nice case, particularly for Travis. So let me show you a comparison here. Make sure I've got the right case first. And it's going to be... Okay, this is an acute case from the point of view of just observation only. So there's some subtle findings, and here there is only 2 days between these two radiographs. So the more recent one on the left in this case here. And I'm going to mag it up here and see if you perceive some small shadows, small opacities that are present here that are not present previously, and how one would describe them. So I looked at this and I said, yeah, there's something wrong. I'm not sure if I'm going to call this reticulation, but it's so acute that I wonder if these small shadows are little tubular shadows rather than discrete rounded shadows. So that's certainly a perceptual test, and I'm not sure how it's going to show up in your screen where you're looking at it now. But I hope at least you'll agree with me that there are small opacities here that are not present there, albeit subtle. So now I'm going to bring up on the right side the CT that was done subsequently, and you'll like this. So here we go. Let me bring it up like that and scroll through that and make that smaller. So this shouldn't be doing that. Let me unlink these a second and scroll through this. So you'll see how neat that is. And this is a really beautiful example of what I call a bronchiolar pattern, because you've got the tree and bud, but you don't really have the buds, but you've certainly got the little branches. So what we're seeing here is a diffuse tree and bud or bronchiolar pattern, just everywhere. And it's a new finding. So I looked at the medical record, and he is a drug abuser, he's homeless, he came to hospital, and every day they asked him which things he was taking, he admitted to more of them. So his tox screen was positive for certain things, and drug abuse is pretty straightforward. So my speculation is that this is probably the cannabinoid, synthetic cannabinoid airway injury case, Travis, which you guys published an article about. And I don't know if they ever got that history that he was smoking synthetic cannabinoid, but he seemed to be doing everything else. So my speculation is that that's what it is. His presentation was not that of an acute febrile illness. But Travis, you agree?
Yeah. Well, and I know what David's question is going to be, which is that he's injecting it too, which because they look identical. But I think this one, he has larger airway thickening, which I would argue in favor of something inhaled rather than injected.
Yes. And I think this is airway. This is not vessel. Not vessel. It's airway. Airway, not, yeah.
Howard, did he have pulmonary hypertension? Were his pulmonary arteries big? Because that would go along with this being arteriolar instead of bronchiolar.
Yeah, no, his vessels look okay to me, I think.
That's good. Yeah, okay.
And I like to speculate that everything happened in that 2-day interval, that he was really, maybe went and binged something in those 2 days.
Oh, those radiographs were only 2 days apart. Yeah, that
Yes,
would.
2 days apart.
Yeah, and David, what's your sense of time frame for excipient lung? Because I know we often see it, and the number of the cases I've shown, it's occurred over the course of months, but I don't know if it's usually one event that precipitates it, or if it's just repeated injection over days or weeks or months.
No, it can be one event. They come in acutely, and they just did it, or they did it the day before. So it starts to occlude the vessels right away, and there's a reaction that bumps their pulmonary artery pressures right up. So it can be pretty acute.
And how many of those cases, when you guys published that series a few years ago in HAR, how many of them didn't have pulmonary hypertension, or did they all have pulmonary hypertension?
I think they all had pulmonary hypertension.
Yeah, so that would be another thing in favor of exposure here, inhalation.
Yes, and the pulmonary arteries here didn't budge between the two radiographs that Howard is showing now.
Yeah.
Yeah, so yeah, that's part of it. The pulmonary hypertension is definitely part of it.
Okay, I thought you'd like that one.
Yeah.
And I know that definitely David's going to like this one. So I'm going to show this one a little bit differently. So I'm going to put up a scout image for a CT done in September versus, and sorry, I don't know why this does this, but let me bring them up together. And the time here is September and more recent. And the finding that I want to show you, at least initially here, that's pertinent is the relative elevation of that left hemidiaphragm compared to the prior. So now let me go back and bring up a CT from September. And let me bring up the axial. So I'll put that over here. And you will see this person has a lung cancer. But notice there's a lot of tumor, probably nodal disease, in that location where the phrenic nerve is at that time, and the central tumor. And certainly when we go down here, and I've learned from David to look for this pretty consistently now, look at the difference in the thickness of the diaphragm and the crus on the left versus the right. So very consistent with phrenic nerve involvement by that tumor. And although the diaphragm wasn't particularly high in September, I think the diaphragm was telling us that it was weakening, it was thinning. And even though she got a little better in terms of the treated nodes over time, so this is January, And although the tumor is smaller and the nodes are better, so made some response, the findings in that hemidiaphragm side to side are still present.
So Howard, had the thinning of the crus gotten worse from the earlier CT that showed the diaphragm at more normal level? The first scout view that you had on the left.
I think that the degree is about the same. So here is September versus now. And I think the degree of thinness of that diaphragm and the crus is the same.
Okay, and we don't have an earlier CT when it had more normal thickness.
No, I do not.
Okay.
No. But I think it's real. I think it's real. Given what we see all in all, I think it's a real phenomenon. And maybe just in the passage of time, the weakness eventually got so much that the diaphragm started to come up. Something like that. You agree?
I agree.
Yeah. Good. I like that case. This one is really an unusual presentation of a thymoma. So I've never seen this one before. So what's really dramatic about this presentation of what was eventually diagnosed to be a thymoma via transvascular approach is how at the time of presentation in this person, the thymoma, which is here, had already invaded to a very significant extent the brachiocephalic vein and the SVC, and you can see all the collateral vessels. And this is at the time of presentation. Here is a FDG exam, and here you'll get a feel again for the extent of the tumor, but so much of it had grown into that brachiocephalic vein and then down the SVC, and that's how you present it. This turned out to be a thymoma, so obviously invasive into the vessel. And it's one of the most dramatic presentations that I've seen. Have any of you seen that, where at presentation there's so much vascular involvement?
Never.
This is just a random thing, right?
Does it look like that Lima graft is involved too? You can see, if you go up higher, it's, I mean, there it's separate, but if you went up a little higher, there was a lot of thickening around it. Just, you know, up higher. I mean, it's, I can't tell if it's open or not. It looks like there's a little contrast in it, but you know, right up in there, see that? It looks like it's almost encased. Just lateral to those clips.
Yeah, I'm not sure. Yeah.
And Howard,
yes.
Where are all those collaterals going? Are any of them going into the pulmonary veins?
There are. So a bunch of these collaterals are trying to sort of come back through the azygos vein.
Yeah. Look at that left superior pulmonary vein.
I'm not sure. Let me have a look. Because lower down, most of them are getting to the IVC. So, oh, that's bright. That's bright. I did not see that. So that's definitely a pathway there, right?
Yep, and it's, I just saw one yesterday with a lymphoma in the anterior mediastinum that was causing SVC syndrome and dumping into the left atrium as well. Like, because I know you've shown plenty of cases of those collaterals developing.
I did. I have, and I went right by this one because I saw the other ones. Yeah, that's a good one. Yep. When they presented him a tumor board, they said at the time they saw him that he had these huge subcutaneous, quite evident collaterals. So even though he's got this tremendous vascular occlusion, he's not symptomatic from it. I guess that maybe if you look up there, you can perceive the subcutaneous ones that they might be seeing and looking at his chest wall. Yep, no, that's good. I didn't appreciate that off the bat. That one right there.
Or did he have any tumor emboli in the lungs anywhere? Or?
Let's see if any of this tumor broke off and went down his pulmonary arteries. Not that I remember seeing anywhere. Just looking for mosaic attenuation and so on.
You think that superior vena cava stuff was inflow artifact, or is there tumor in the superior vena cava coming on down?
Certainly here we have tumor. Sorry, I'm going so fast. There's tumor to that level. Azygos vein tumor there. or slow flow or thrombus or some combination of things. I'm not sure, David, exactly.
How about following the PET down? Does the PET go down that far?
Yep. Let's have it go down to about there. Kind of peters out. Doesn't. There's a little bit right there, actually. Down the side.
Yeah.
Okay. Yeah. Maybe down that side there. That's pretty dramatic, isn't it?
Indeed.
Okay, I can save my others. Well, let me show one real fast because this one's really neat. I've never seen this before. So we've all seen pretty dramatic type A aortic dissections. And very quickly, tell me if you've ever seen one in which there is so much thrombus at the root of the aorta in that false lumen. So look how dramatic this is. Let me just go from above a second. And this is the big false lumen here. That's that really skinny true lumen. So going down now towards the aortic root, we can see all of a sudden this huge thrombus. And that's what they found, thrombus in the false lumen in the aortic root, very large. I don't know what it was actually doing to the aortic valve. I don't remember seeing a description of that at surgery, but they did encounter what they described too as a large thrombus at the root of the aorta, which is in the false lumen, like that. I don't think I've seen that before. Skinny true lumen where the coronary artery comes off, right? I don't know why that happens, and that's pretty dramatic, but it's the first one I've seen like that. So they took that out and they replaced the root of the aorta and so on with the graft.
Yeah, that's pretty scary. There's not much true lumen there in the proximal ascending aorta, is there?
No, isn't it? It's just on the side here, right? You can see where the LCA comes off. It's just a little true lumen right down here, down there, and there's the left main, some atheroma and so on. And then the RCA comes off there. It's pretty dramatic, isn't it? All right, everyone, that's it.
All right. Great cases, everyone. Thanks.
Okay, see you next week.
Bye.
We will reconvene next week.
Thanks.
All right, take care.
Okay, bye, everyone. Okay. Great.
When you look at hearts a lot closer.
I know, I didn't even see that. I know, that was what's crazy.
Well, one of the things about that is that